Uh, Today, I will talk about Quadratus Lumborum block, QL block, its easiness, safety, and effectiveness. Let's move on. First, I will talk about analgesia for the trunk with epidural. As you know, epidural is always the almighty for us anesthetists. Epidural is the gold standard for laparotomy. It is recommended in early recovery after surgery for laparotomy. Epidural can affect both somatic and visceral pain, so it is effective. There are some other analgesia. Opioid is effective for only visceral pain because opioid is effective for C fiber. But opioid is not effective for somatic pain because it is conducted via a delta fiber. Epidural is the almighty, but sometimes has problems. Now, the adaptation. Epidurals cannot be performed with abnormal hemostasis, like heparin, warfarin, factor 10A inhibitor, and so on. And also, it is difficult with spinal deformity or after spinal surgery. And sometimes epidural can cause terrible complications. Epidural hematoma. It might happen very frequent. And sometimes, especially for elderly, epidural can cause hemodynamic instability. And some other minor problems, urinary retention, unilateral effect, and so on. And more patients cannot receive epidural analgesia in the future. So we need the alternatives. IVPCA. It is not effective for pain on movement. Opioid is not effective for somatic pain. And it does not contribute to early ambulation. And opioid can suppress intestinal motility. So difficult. And other analgesia, local infiltration analgesia, LIA, we call it LIA. It is very effective for pain on movement, and it can improve patient satisfaction and also decrease opioid consumption. But it does not contribute to early ambulation. Then we have to think about nerve blocks for the abdomen. Our main target is ventral rami of spinal nerves. The nerves in the picture. We know TAP block is effective for 24 hours after laparotomy to suppress T7 to L1 somatic pain. It is published by Dr. McDonnell. However, TAP block under ultrasound was effective only for lower abdomen. It was published by Dr. Shibata in the same year, 2007. Now we know TAP block is effective for lower abdomen, And the subcostal top block is effective for upper abdomen and sometimes upper and lower. And rectus sheath block is for midline incision. We can use top block, but sometimes there are rebound pain stories after top block. The mechanism should be like this. The surgical pain is once controlled by top block completely. Next, we anesthetist does not use unnecessary anesthesia and says opioid after block because patient has no pain. But next, the effect of top block diminish after inappropriately short duration, and the terrible pain comes back. Now we have to think of the duration of the anesthesia by the block, which causes more appropriate pain. Number one is natural cause, and this red line. It is so painful, and we use many kinds of analgesia. Top block is number two. The effect is complete, but very short duration. So soon after the block, the pain comes back. It is not suitable for surgical wound. We need number three. If the anesthesia is incomplete, but long acting is necessary. So how long the effect of top block lasts? We measured it. Only 8 hours after block, the patient require rescue anesthesia. RSB is rectus sheath block and top block. Two blocks are very short. And new block has come. I will introduce about QL block. And think about it. Why the original top block was effective? There should be this kind of truncal block, maybe, and effective for 24 hours and to suppress upper and lower abdomen. Back to the original method. Dr. McDonnell's landmark top block is like the image left. And Dr. Shibata's ultrasound guided top block is in the right. The point of injection is very close, but not same. It's different. So maybe the difference in the duration and the spread could be because of this. It on our article. And top block and QL block is like this. Top block is between internal oblique and transversus abdominis. And QL block is more posterior, more dorsal. It is a transsectional view. It is totally different. We confirm the spread of the color dye in cadavers. How much volume is needed for top block and QL block? we use 5 to 25 milliliter injections. And top block is the left with 10 milliliters, and the spread is very narrow between T10 to T11. But with 20 milliliters, the effect spreads T10 to L1. Of course, we all know about it. And for QL block, 10 milliliter cannot spread upper, only between T12 to L1. But with more amount, the drug spreads gradually to the upper. And with 20 milliliters from T8 or T9 to L1. So maybe for QL block, 20 to 25 milliliter is required. And also, we evaluate the safety of that block. The graph, the picture is arterial ropivacaine concentration after block with 150 milligrams. The stripe box is after top block, and the maximum concentration is very high, sometimes over 2.2 microgram per milliliter. It can cause local anemic toxicity. But after QL block, the ratio is lower by half. So QL block is more by far more safe. And it is the efficacy evaluation. Duration of analgesia. With same approach, we measured the duration of top block and QL blocks. The time from block performance until the first rescue analgesia was compared. The duration was, as you can see, QL block is very long, more than 24 hours. And the spread, it is a clinical spread. The spread was evaluated with loss of cold sensation. With lateral top block, the cold loss was from T10 to L1. And for QL block, cold loss was from T7 or T8 to L1. It is a summary. Safety. QL block was much more safer than top block. Top block can cause last systemic toxicity with usual amount of local anesthetic. And analgesic duration. The effect was by far longer after QL block than top. QL block lasted for 1 day and no rebound. We have never experienced no rebound pain. And the spread of the effect. As you already seen, after QL block, the spread was far wider than after TAP. And now, talk about the future prospect. Actually, there are so many approaches of QL blocks. Dr. Blanco published QL block 1 and 2. And there are one more, transmuscular QRB, or sometimes called by QL block 3. And our QL block is intramuscular injection. Now we have 4 kinds of QL blocks. And what we do not know now is QL block as effective as epidural or not? And the block can work for 1 day, but sometimes we need more, 2 or 3 days or 1 week. So continuous QL block can be possible or not. And it is sometimes academic question. QL block can cover the visceral pain or not? And it is our question. Our intramuscular QL block can cover QL block 1 or 2 or 3. Okay, that's end of my presentation. And actually, Dr. Moreno gave me some questions already, and I will answer. Can I talk now? And this is a question and answer slide 1. How can we use QL block for what kind of surgery?
Takeshi.
Yeah?
Enrique speaking. Yes, we have we prepared 3 questions for you.
Okay.
I want to do this question. The first one is, wait a moment, please. I check my iPad. The first, which indication for Quadratus lumborum block do you do for this? For what kind of surgery do you use Quadratus lumborum block? The second one, which is the volume and concentration for longest analgesia? And the third question is, which contraindication do you see for Quadratus lumborum block? Okay?
Okay. Yeah.
Yours.
Okay. For question number 1, this is the answer. For virtually every type of abdominal surgery, we can perform a QL block. For open surgery, colon surgery, liver surgery, gastrectomy, gynecological surgery, and so on. In our hospital, QL block is routinely performed for abdominal aortic reconstruction surgery, AAA surgery. And of course, it can be performed for laparoscopic surgery. We need less opioid. And for orthopedic surgery, QL block is good for iliac bone harvesting when they need to take bone from anterior superior iliac spine. It is very good adaptation. And then for the second question, the volume and concentration for QL block. Our recommendation from our data and clinical impression, we need 25 milliliter per side. And the concentration, we need only 0.25% level of bupivacaine. But for ropivacaine, these concentrations are not good and more concentrated at 0.375% is needed. These amounts are considered to be safe and effective for 24 hours. And for catheters, we now have no answers because we have no experience of catheters for cure block. And last question, contraindication for cure block. Actually, we performed many cure block, but we have never experienced serious hemorrhage or suspected nerve damage, of course. And now we perform cure block even if coagulation is not normal. However, we have to pay attention the effect of factor 10A inhibitor. Sometimes this kind of drug causes terrible hemorrhage. So we don't like this drug is if this drug is continued, we don't like to perform cure block. And that's all.
Thank you again. We are very happy for your lecture. It was very interesting for us, and we expect to use this kind of block many times from now. And thank you, and good day. See you.
Okay, thank you.
Bye. Bye. Thank you.
Bye.